All right, okay, we're recording.
All right, so what's up, everybody? So we're doing our presentation on Avastin use in glioblastoma brain cancer, and yeah, I hope you guys enjoy it. So let's get started. So first, we're going to start off with the biology of glioblastoma. So it originates in tissues of the central nervous system, so the brain, the brainstem, the cerebellum, and the spinal cord. And the cells of origin are the astrocytes and oligodendrocytes. The oligodendrocytes, they really just deal with making myelin and providing your myelin sheath. And then your astrocytes, they kind of protect the cells in your brain and stuff. They produce antioxidants and stuff like that to help you out. And it also affects neural stem cells. So the tumor type, it's called a glioma, and it's a grade 4 glioma, which is just a malignant, fast-growing tumor. And it's also called an astrosoma because it affects the astrocytes and has 4 biologic subtypes. And this is based off of just different ways that proteins and stuff are transcribed. So you have classical, proneural, neural, and mesenchymal. So moving on. So the mutation that occurs in these tumors that really helps them proliferate and grow and get out of hand is a mutation in the retinoblastoma gene. We talked about this a little bit in class. So the gene's function is it produces retinoblastoma protein, so RB1 protein. And when this gene is mutated or it's deleted, you can't produce that protein. You don't produce RB1. And then it allows for the cell cycle to just go out of control. So things go into S phase and it's no longer blocked from going into S phase. And so the cells can just divide and divide as long as they want. So the process, how that really works is the retinoblastoma gene, it codes for RB1 production. And so that protein, once it's produced, it binds to something called E2F, and it forms a complex called the RB-E2F complex. And that complex basically blocks cells from going from G1 into S phase. And when you're no longer able to create that protein, RB can't block E2F from moving into and changing from the cell cycle from G1 to S phase. And so it just goes unchecked, and then you get cancerous cells and tumors. And lastly, so the process that Avastin targets in the cell cycle, the hallmark that it disables is angiogenesis. So basically, angiogenesis is the formation of new blood supply to support the cells. And glioblastoma, it needs a lot of new blood vessels. It's highly vascularized, so they thought that this would be a good target. It uses VEGF to recruit these blood vessels that support the tumors in order to block them. So Avastin blinds VEGF, and it stops it from adhering to its receptor, which is just called VEGFR, and it stops the attraction of the blood vessels, and it starves the tumor for nutrients and oxygen and things like that. And if you look at the picture that I have at the bottom, you can see that the use of Avastin, it's going to block the signals that are allowing the blood vessels to come towards the tumor. And you're going to see that the blood vessels will shrink away and the tumor will shrink as well. So that's it for the basic biology.
All right, so the epidemiology of glioblastomas, I'm Sam, and I'm going to tell you about that. Glioblastoma, so the major health concern regarding glioblastomas is that they're one of the most deadly and rapid growing forms of cancer. And you'll see that with the mortality rate on the next slide. But every year in the US, around 10,000 people are killed specifically because of the primary glioblastomas. The median age at which patients are diagnosed with them is around 64, and they're seen in higher rates of incidence in the older you are. The current incidence rate is 3.19 per 100,000 persons in the United States. So it's not very common, but it's still, people who do get it die at a really high rate. And the incidence seen in males is almost 2 times higher than the incidence in females. And Caucasians have rates roughly 2 times higher than seen in African Americans and almost every other non-Caucasian race. And the lowest rates of incidence are seen in Asian Americans and American Indians. Um, and as far as other countries outside of the US, high rates of incidence are seen in Australia, Canada, New Zealand, and Finland, and low incidence rates are seen in the Philippines and India. And these charts show that too. And so, like I was saying about the mortality rates of them, the prognosis is not very good. The median survival time is only around 15 months from the diagnosis, which means that 50% of the patients who are diagnosed are dead by 15 months, and less than 5% live past 5 years, and almost none of them survive past 10 years after diagnosis. But the survival rates reflect the incidence rates. So the Asian Americans, American Indians, and then Japan and India have the highest survival rates out of all of the differing groups. And so risk factors regarding development of glioblastomas. So like I said, the older the age group, the more the incidence rate goes up. Being male, like I said, they have almost a two times higher incidence rates than females. Um, Inherited gene mutations, they're really a really rare risk factor. It's seen in, I think, like 2% of the population I read. So that it is a risk factor, but that's really rare. And then ionizing radiation exposure, that's the only identified environmental factor that we know of that contributes to the primary growth of glioblastomas, or the growth of primary glioblastomas. So I'm going to talk about that risk factor. So the observational study that I went over with the risk factors of ionizing radiation, what it did was it took 8 different cohort studies and analyzed the data from them to try and get a sort of like meta-analysis on how ionizing radiation affects the development of brain tumors. So the goal of it was to see if there was, in fact, a significant correlation between exposures of ionizing radiation and the development of glioblastomas. And they also, it wasn't just glioblastomas that they considered an outcome. They also did other brain tumors as well. So as I said, the exposure was exposure to ionizing radiation. And they did this in 2 ways, either exposure through disease treatment, as like mostly young kids who developed brain tumors at a really young age, they would treat them with ionizing radiation. And then also in one, I think it was only one study that they took, they used a group of people that were exposed to ionizing radiation through living in the area where an atomic bomb was dropped. And again, the outcomes were the development of the glioblastoma and other types of brain cancers. And since it was 8 different cohort studies, the populations, the age, the place, the race, and also the dose at which they were exposed to it differed. So moving on to the next slide, I'll show the results. So the results from the 6 studies, or in 6 of the studies, showed a significant increase in brain tumor development when exposed to the ionizing radiation, especially in younger ages. One of them, the first one right here, it actually showed a decrease in it, but all of the rest, and then one of them showed an increase, but it wasn't significant. But the other 6 showed significant increases. And overall, the heterogeneity of the studies had a p-value of 0.03, so indicated that it was significant, and it indicated that there is a correlation between increases in brain cancer and exposure to ionizing radiation. But the downside of this is that because of how they used 8 different studies and they were all they weren't all done at the same time. They just collected data of the studies that were already done. Their definition of exposures or their doses differed a lot, and then also the groups of people that were sampled for these studies differed, so that kind of hindered them from determining differences among populations of people. But they did find that ultimately there was an increase in the brain cancer when exposed to ionizing radiation. They just don't, that more studies will have to be done to determine differences in the increase among different populations. And then finally, one interesting thing I found about it while researching the ionizing radiation is that although it is known and accepted as a risk factor for brain tumor development, it's actually one of the only treatments that they use to treat against it, because it's a really strong radiation. So when kids are young, they'll give them the ionizing radiation to try and treat tumors, and then later in life it's a risk factor for them. But then since it's one of the only strong enough radiations to kill cancer, they use it later in life to try and stop it in combination with chemo. So I just thought that was interesting.
All right. So talking about Avastin and how effective it is in glioblastoma, like since people die so quickly in about 15 months, they needed to find a way to treat it other than just with normal traditional chemo and surgery, right? People are dying 15 months. It doesn't really, like the medication needs to help along with that. So Avastin is approved only for recurrent brain tumors, right? So only after someone's already had surgery and already had radiation and they failed it and the tumor is growing again, do we use Avastin in the United States. So Avastin is not really approved in a whole lot of countries for various reasons, which I'll go into, but it became like approved by the FDA based off of some evidence that they received in a phase 2 trial in 2009. So 2009, they had this phase 2 trial and they were testing Avastin with chemo versus Avastin alone, and just trying to see if there was tumor shrinkage and how long was there the shrinkage before it started growing again. And so in the phase 2 trial, they actually did see about 25.9% of people having a reduction in size of their tumor or a halting in the growth of their tumor with Avastin with chemo versus Avastin alone. And it lasted for about four months roughly, which isn't great, but when you only have 15 months, you know, where you're going to survive, it matters, right? So based off of that, they said that this was a medication that we want to keep going on with. And so after that, there was another study that was done in Europe. So this isn't a study that was done in the US, but it is referenced on Avastin's like website. So in 2017, they wanted to see what Avastin with chemo was doing with Avastin or with chemotherapy alone, right? Really, they wanted to see what a phase 3 trial would look like, since everything was approved in the US based on the phase 2 trials. So they determined after, 2 years plus that there really wasn't a whole lot of change in the overall survival between the two groups, right? So they're still dying at about the same time frame, despite having the Avastin and chemo versus just the chemo alone. So there was a significant difference, and that's what they like focus on the website, is the significant difference in the progression-free survival of the two groups. So progression-free survival is four months roughly with Avastin and chemo, and only a month and a half with just Avastin alone, right? So, hey, or with not just with Avastin, with chemo alone. I put a typo, I guess. So there is a significant difference for whatever reason. Avastin helps prevent that first initial progression-free survival, but it's not really affecting the overall survival later on. It's still approved in the US for use, uh, mainly based on the phase 2 trial, and it doesn't look like it's doing a whole lot of harm. And you could sell the progression-free survival as an aspect for treatment, and it's up to the patient at that point for a lot of care in the US if they want to take it. Yeah. So, all right. So there's a lot of health risks that come along with the Avastin use, mainly because, like we were talking about earlier, how it works, right? It's attacking, or it's preventing the blood vessels. So there's about 63.6% of patients are gonna have some really bad health risks involved with taking it, right? So these are associated with Avastin and not necessarily just with the chemo, but the chemo doesn't help, right, with most of these things. So you're getting gastrointestinal perforations where there's holes being eaten into the intestine where you could have some spillage, which isn't great, obviously. A fistula is kind of like a hole, again, that can happen somewhere else. You see it in skin and other things like that. Arterial thrombolytic events. So that's just, they're throwing clots. It's getting stuck somewhere, so you could maybe have a stroke or something like that alongside of it. Hemorrhaging is going to be worse. Renal injuries happening. You're going to have protein in your urine. The incidence of wound healing just plummets, right? You're just having a lot of issues maintaining your vascular system while you're taking Avastin, obviously. And so 64% of people are gonna have those issues in taking Avastin with chemo. So again, it's a lot to ask of a patient to take on when there's not a whole lot of overall survival changes, right? And then we have to think about like costs, right? So like how much does Avastin actually cost? It's really hard to figure out how much medications cost in the US because a lot of it changes based on your insurance, like if you qualify for any kind of breaks, what kind of insurance you have. So even on Avastin's website, if you went on there and you're trying to figure out if you could even afford it, they don't tell you straight up how much the Avastin is going to cost, right? They put you behind like a questionnaire and give you a bunch of questions asked. Do you have insurance? Okay. If you don't, you need to talk to one of our reps. Maybe we can find you a break. Do you have good insurance? Maybe if you don't, you need to talk to one of our reps. So at no point are they actually telling you the cost because it costs a lot. So around $842 was the only kind of cost that I could find for Avastin, and it wasn't necessarily for glioblastoma. Just in general, $842 for 4 milliliters. You're gonna need 10 milligrams per kilogram, your own kilograms, every 2 weeks. It's a lot. So an average man in America is weighing 190 pounds now. uh, it's a lot. So to figure out how much it was actually going to cost, there were studies that were done in Canada and in China, both of which have socialized medicine, and trying to figure out, is it actually worth it to to their patients, to their taxpayers, um, based off of the studies that have been done. So the one I'm going to talk about mostly is the Chinese one, because they break it down a little bit better. But it it was looking at the cost benefit analysis of Avastin with chemo versus the chemo alone. Now, the chemo that they decided to use in the study is the one that they chose in the phase 2 trials and not the phase 3 that was done in Europe. The costs still equated about to be 30,000 roughly more than just the chemo alone. So if we look all the way down here, the ICER, that's about the treatment costs that we're going to see with this kind of stuff. So $171,000 is what they're really expecting to pay per person for this treatment, which, they're mostly dying. In 15 months, they're going to be paying $171,000. And China does not have that kind of money per person for their medical expenses. So normally it's about 25% or $25,000. Canada itself was $100,000, but their costs were even higher because they're having to pay more for their doctors, they're having to pay more for a lot of things. So even in Canada, it's not approved to pay for Avastin in conjunction with chemo, just because it increases the cost so much, but doesn't really change the effectiveness of it, and it doesn't actually help a whole lot of people. And if anything, because of the health risks experienced in 64% of people, it may actually end up hurting the people that you're trying to help. We can't hear you, Carrington.
Can you hear me now?
Yep.
Okay, perfect. So I'm going to discuss the clinical course of the disease. So there are 4 subtypes: classical, mesenchymal, neural, and proneural, and they are divided based on abnormalities in 4 different genes: gene PDGFRA, 1DH1, EGFR, and NF1. And the picture on the screen also shows more common genetic changes in the different subtypes. The prognosis, once diagnosed with the disease, is poor, as we've discussed, and there is a short life expectancy after diagnosis. Life expectancy is so short that long-term glioblastoma survivors are defined as patients who live longer than 2 years post-diagnosis, and extreme survivors are considered patients who live 10 years or more after diagnosis, and they are less than 1% of all patients. Once diagnosed, treatment usually begins with surgery to remove as much of the tumor as possible from the brain. Because it spreads into the tissue surrounding the tumor, it kind of spikes out and makes it hard to remove. So radiation and chemotherapy are the next treatments to decrease the size of the tumor and remove as much of it from the brain as possible. And Avastin is also used. It is an anti-angiogenic drug, and so it helps cut off the blood supply to the brain's tumor and also to the normal cells, unfortunately, around the tumor. And it's very effective in patients who have already gone through chemo and radiation as a somewhat last resort effort, and it has increased progression-free survival and overall survival in some patients by a few months. And then, as I've already discussed, it is an anti-angiogenic drug, and so it blocks VEGF, a vascular endothelial growth factor, which is a protein, which is helps the new blood vessels supply blood to the tumor and increase the size of the tumor and help it spread within the brain. Avastin can also treat breast cancer, colon cancer, rectal and some lung cancers due to its anti-angiogenic effect. Its off-target effects are nausea, hypertension, gastric ulcerations, and ocular damage, which are caused by the binding to beta-2 receptors, tyrosine kinase receptors, and NO synthase in the brain, which its binding causes the receptors to perform different functions than they are assigned to, and to cause these issues within the body.
So I wanted to thank everybody for watching our presentation about glioblastoma. It's a rare disease and it doesn't affect a whole lot of people, but it's something that we should put more attention into, just because it's such a rare occurrence. You know, how are these cells inside the brain becoming abnormal, right? You know, part of it is ionizing radiation, but not all of it. So the more that we know about glioblastoma, it could help shine light onto other cancers and potential treatments. I would ask if there's any questions, but seeing as we're talking to a YouTube crowd, probably not. Next are our references, and that is it. Thank you all for your time.